Thank you so much for letting me present here today. This is my affiliations to disclose. The effect of pregnancy on the pelvic floor in the long term is still unknown. Therefore, the relative effect of vaginal delivery and the potential protective effect of a cesarean section are still unresolved issues. The aims of this study was to compare the prevalence of symptomatic pelvic organ prolapse in women 40 to 65 years of age in nullipara, after one pregnancy, and vaginal delivery, and the calculated risk reduction by a cesarean section. In this study, we used age and BMI-matched cohorts of nullipara and one-para women. In all these pairs women, they were surveyed 20 years after birth. We used self-administered questionnaires and used a restricted definition of symptomatic prolapse. The prolapse symptoms was defined by the key question: do you have a sensation of tissue protrusion, a vaginal bulge from your vagina? The response often and sometimes were a yes, but the symptom infrequently was not considered symptomatic genital prolapse. To reduce the risk of bias due to unknown confoundings, we use large, randomly selected cohorts from national registers such as Statistics Sweden and the Swedish Medical Birth Register. Over 500,000 of women were eligible, and a random sample of 30,000 women were invited to participate. Out of the 30,000 women, 14,000 responded, and that resulted in 3 groups: 9,000 nulliparous women, about 4,000 vaginal delivered women, and the smallest group, the C-section group, about 1,400. The cesarean section group was a mix between elective and emergency cesarean section. All these women were available for a matching procedure, and finally there were 1,300 women in each group left. To estimate, To estimate the effect of pregnancy, we compared the cesarean section women with the nulliparous women. And to estimate the effect of a vaginal birth, we used the cesarean section women together with the vaginal delivered women. This figure shows the line plot of 3 different logistic regression models. Vaginal delivery, the red line, cesarean section, the blue line, and the nullipara group, green, they were all between 40 and 64 years of age. As you can see, at 40 years of age, there were actually no difference in estimated probability of symptomatic prolapse in all 3 groups. However, in the vaginal group, the probability of prolapse was doubling for each 10 years. In nulliparous women and women after cesarean section, the probability of prolapse was low and relatively similar during the study period, during the period 40 to 64 years. However, BMI was not a risk factor for symptomatic prolapse in any of the groups. There was no effect of cesarean section on symptomatic prolapse at 40 years of age. And the risk reduction, there was no risk reduction with the cesarean section at 40 years of age. At 52 years of age, the protective effect was increased, not only for prolapse, also for bothersome prolapse, for the combined symptoms of urinary incontinence and prolapse and fecal incontinence. The protective effect of cesarean section in 64-year-old women was substantial and amounted to more than a 90% reduction in symptomatic genital prolapse and for the bothersome forms of prolapse. C-section was also protective for symptomatic prolapse co-occurring with urinary and fecal incontinence. So in conclusion, after 40 years of age, vaginal delivery increased the risk of symptomatic prolapse, which almost doubled for each 10 years. Pregnancy alone did not seem to have a long-term effect. And vaginal delivery therefore seemed to be the dominant predictor of symptomatic pelvic organ prolapse. Thank you.
Thank you very much. This paper is now open for comments, and we welcome your question. Please say your name.
De Leeuw, the Netherlands. Thank you very much for this beautiful study. Very interesting. I'm so curious. I'm very curious about your discussion with the perinatologists and midwives in Sweden that you have, because my experience in Holland with perinatologists and obstetricians who are always talking about the rising cesarean rates, and I was so curious, how do you end your discussions with them?
We try to just inform them about our results, and I think the women, the patients, are our best guides in this way. They ask the midwives, and they actually ask for information. What can happen? What's the result?
Do you think that they get a good answer from midwives and obstetricians?
In a short while, I think they will. We have to feed them with information about different aspects of a vaginal delivery, and of course also for cesarean sections.
I'm not so optimistic, to be honest.
So as you know, this conversation about mode of delivery is very complex with many, many factors, and there's no single answer for any individual patient. In the prior talk, we talked about the microbiome seeding issues of the infant's health, and that's still relatively new data, so that has to mature and be weighed. But do you have a sense of what's the best way to convey this very complex information to a patient so that we're not leading her to the desired result that we value, but rather the one that she values?
I'm sorry, was that a question? I'm not sure.
My question to you is, how do you think we should have the best conversation with the patient to capture all the complex information she needs to make a decision about mode of delivery?
Well, we have to be better in information, and we have to have more knowledge about different aspects of the different two modes of delivery, and also we have to try to find subgroups that are more at risk than other groups.
Thank you. I think we have another question. Please identify yourself.
Yes, I'm Philippakos from Lugano, Switzerland. I have two questions. One is actually similar. Did you see, the first one is, did you see any difference in the two groups of C-sections? And the second one is, how do you consult your patients? Do you tell them about the risk of prolapse for the decision of delivery? Thank you.
Yeah, the answer to the first question is that we have published before that there were no differences in urinary incontinence or prolapse symptoms between acute and planned cesarean section. It seems that the damages occur at the last contractions when the baby's head is born. The second question, how do I inform the patient?
Do you inform them for the risk of prolapse if they give vaginal birth?
Well, actually, I'm a urogynecologist, and I don't talk so much with the obstetric patients, but I try to inform my colleagues, and I think the women are the ones who are asking the questions. And we try to have the discussion open at the clinic, but it will take some time. But I think the women, the pregnant women, will be the driving force in this case.
So you would inform them?
Sorry?
You would inform the patient of this risk?
Of course.
Okay. Thank you.
I'd like to make a comment to our dear colleague from the Netherlands. I think you're quite correct. I think we need to have a dialogue with our obstetricians. You know, there are figures showing that approximately 20% of women in their lifetime perspective will either have a prolapse surgery or incontinence surgery. And then we have the microbiome problem. But the obstetricians today, they're basically thinking about the immediate effects of delivery. Asphyxia, bleedings, thromboses, major problems that can occur. They don't really have the problems that we're discussing here with pelvic floor problems in the future on their radar. And we need to put it on their radar in the future. So we've tried many times to get discussions. I talked to the Royal College in London to have a joint workshop, obstetricians and pelvic floor experts. I think the time is necessary to do that. I think Linda would agree with me on that.
Any other comments or questions? We thank you for a really outstanding presentation, very thought-provoking. Thank you very much.
Thank you.